This is Dr. Sakhnini speaking, thrilled to introduce the surgical technique for ulnar shortening using a mid-artis implant. I have nothing to disclose. I use multiple implant. This is the patient, female patient with ulnar abutment following distal radius fracture with shortening. The approach is ulnarly on the ulna with a straight incision. We place the incision from the base of the ulnar styloid proximally. We want to place the plate as distally as possible on the volar part. So the approach is between the FCU and the ECU. So we will have to open the interval between them and make a little room under the FCU with the help of a rasp. And we take crossing vessels, mainly veins that cross in the surgical field. Now we open the fascia and some part of the periost and mainly the fascia of the FCU in order to make a room for the plate. So following this, the next step would be to stabilize the plate against the ulnar bone with the help of a K-wire, followed by drilling usually the distal part with the help of a compression screw. We use also a special jig drill guide in order to stabilize the plate also in the proximal part. And this is the plate. We see that we have to enlarge our incision in order to fit. This is the ulna. It comes into view under the FC. This is a 2.5 system. So the first step would be to stabilize it and then drill usually the distal part followed by the proximal part. This is a good position of the plate. It's distally. We use a fluoroscopic guidance to make sure that we are in the right place, and then we do the drilling. The plate looks fine, the good position. This is the compression jig that we use, the proximal part. We drill as proximally as possible and put a compression screw in the most proximal part of the oblong hole. So now we have proximal and distal compression screws. We can also put a distal looking screw to further stabilize the plate before we do the osteotomy cut. So these are locking screw that we put distally as we go on with the surgery. The compression element is already mounted on the plate. Now the next part would be to pre-drill through the proximal end of the basic element and insert the temporary tension bolt. So this is the next part as we go on with the surgery, and this is the tension bolt. Now we are ready to do our cut in order to shorten the ulna. So the jig is already mounted, as we can see here. The cut is dorsal. We use an oscillating saw, and the jig is already on number 0. This is the first cut. Following this part, after we make it, we need to decide how much we need to shorten. So we can do between 2 and 8 millimeters. In this case, we took the decision to shorten the ulna by 4 millimeters, which will be enough to obtain our goal in order to make the ulnar surface level with the radial surface, in order to make the druge congruent and alleviate the pain of the ulnar abutment. So we here take the proximal cut. Our goal is to make sure that the cuts are parallel in order to help with the compression eventually when these two bones glide against each other. We need to take this piece and use a Hohmann Spitz and osteotome to help take this piece of bone. We can use multiple instruments like a Kocher, tweezer, or a scalpel in order to take it. And now we will loosen up the proximal screw, and we will loosen the integrated screw in order to do the compression. So this is the most important part of the surgery. We can see here that we utilize a screwdriver in order to push the plate to make it glide and close this gap. We can use a lion jaw or a crocodile instruments in order to guide the gliding of the bone, not to make an over compression or gliding of the two parts of the bone. Now after this we close the compression screws, and we utilize a lag screw that it is perpendicular to the cut in order to compress the two parts, helping with the union. So it's a built-in mechanism that help gain our goal as easily as possible to make a cut, to shorten the ulna and make a compression. Now we put the proximal locking screw in order to gain good hold of the plate against the bone with three screws proximally and distally, and one crossing the fracture site with a locking screw. After this we take out the jig, and the system is already, as we can see here, is open to utilize as much cortical screws or locking screw as we want in order to stabilize further this construct. So this is the surgical technique of this specialized system of mid-artis 2.5 millimeter. In this surgical approach, we have to make a lot of choices, starting by placing the plate at the right location, deciding how much shortening we need to do. We don't want to make ulna plus ulna minus, so we have to make measurements beforehand in order to make sure that we take the ulna to the right place. The problem is doing over shortening, which is also problematic. It can cause a problem with the rouge, which the congruency of that rouge eventually will affect the prosupination range of motion. We use a fluoroscopic guide throughout the surgery in order to see that the gap is closed and that we have enough compression and that we are satisfied with the implant. You can see here that we have a good outcome. This is before the surgery, this is post-op. We have a good leveling of the ulna, good shortening. We profusely irrigate the wound and close. We start by closing the fascia between the FCU and ECU. The first step is to cover the plate, bury it before we start closing the subcutis and the skin. So we were very technical when we try to guide you through the surgery. We did not discuss the indication for this popular surgery. In this case, we had a ulna plus following a trauma. It could be ulnar abutment syndrome that could be idiopathic or primary, or treating a long-standing chronic pain of TFCC lesion that could be alleviated with only ulnar shortening. The procedure could lead to improvement in pain and range of motion. Two possible complications of the surgery is injuring the dorsal branch of the ulnar nerve that cross above the ulnar styloid. In order to do it, we have to do a very distal incision. and non-union of the fracture. We can deal with both with a proper surgical approach. We irrigate the oscillator during the cut in order to cool out the bone, preventing necrosis. And we allow early range of motion in the post-op. I hope that you enjoyed this video and could apply this system in your practice. Generally speaking, the surgery is rewarding with very good outcome with anticipated pain alleviation. I thank you again. I hope that you enjoyed the video, and Assalamu alaikum.